Disclosures for this and all episodes in this series can be found on the podcast series destination page located on education.webmd.com. The following presentation is copyrighted by WebMD Education. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of WebMD Education. The following podcast is supported by an independent educational grant from Moderna, Inc.
Hi, this is Dr. Michael Davis. I am professor and chair of the Department of Melanoma Medical Oncology at the University of Texas MD Anderson Cancer Center, and I am the president-elect of the Society for Melanoma Research. It is my pleasure to host this series of podcasts discussing some of the key topics in the management of patients with advanced melanoma. And in particular, it's my pleasure to introduce our session today, focusing on the evaluation of the use of immune checkpoint inhibitors in melanoma. Our discussant today is Dr. Michael Postow, who is chief of the melanoma service at Memorial Sloan Kettering Center in New York City. Mike, the field of melanoma and the treatment in particular, of patients with stage 4 melanoma has really been revolutionized by the approval of new immune checkpoint inhibitors. At this point, for patients with stage 4 melanoma, we really have multiple immune therapies to choose between. I'm wondering if you could just sort of provide your perspective of what you think are sort of the strengths and optimal use of each of these different immunotherapy regimens in the management of stage 4 melanoma patients today.
Thank you very much, Dr. Davis. It's a pleasure to join for this podcast. And as you mentioned, we have a lot of new tools in our toolbox to really treat patients with unresectable stage 3 or 4 melanoma in dramatically better ways than historically. And I think the challenge that we have now is which treatment for which patient and when. When do we use single agent PD-1? When do we use PD-1 in combination with relatlimab, like nivolumab and relatlimab? And when do we use nivolumab plus ipilimumab? And in thinking about this, one can think about this on a spectrum of kind of aggressiveness in terms of treatment and side effects, and also aggressiveness in terms of the patient's disease, and then also kind of a perception on how the patient weighs side effects and expected efficacy. Well, as you step from single agent PD-1 to the nivolumab plus relatlimab combination to the most aggressive nivolumab plus ipilimumab, how much incremental efficacy are you kind of getting along the way, and what do you really need for your patients? So I guess I'll start kind of with nivolumab and ipilimumab because we have really great data for efficacy in patients with brain metastases. And those patients that I really worry, I may only have one shot on goal. And if they don't respond to initial frontline systemic therapy, we're going to have some problems. So in those patient populations, I kind of lean toward nivolumab and ipilimumab. And I think that's where people wonder, where's nivolumab and relatlimab going to kind of rest in the spectrum? I think it's going to replace a lot of single agent PD-1 because we have a regimen that has a higher progression-free survival and pretty good toxicity. The toxicity of nivolumab and relatlimab is just a little bit worse than single agent PD-1, but the efficacy is also a little bit better. And so most of my patients, when they're thinking about single agent PD-1 or a combination with nivo and relatlimab, they'll tend toward thinking about nivo and relatlimab for that reason. And kind of how we decide between nivolumab and relatlimab and ipi-nivo combination, that's a lot of challenging considerations, some of which are the patient factors that I brought up earlier. But I think that's how I kind of think about these kind of three frontline immune therapy regimens in unresectable stage 3 or 4 melanoma.
That's a really great overview, Mike. Thanks so much for doing that. And, I think one of the things that you and I have talked about too is one of those other factors, as much as we focus on where the disease is, how much disease there is. I think the other thing that's really important as we think about, the relative risk benefit ratio for these is the support network that patients have. And I tend to think about patients, again, who have a good support network and good access to medical care as being different from those patients that we see who come from very isolated areas or with very limited sort of support in terms of what the relative risk would be of some of our more toxic regimens.
I absolutely agree. I think that's incredibly important, especially for the nivolumab and ipilimumab combination, where patients frequently have to have immunosuppression and need to retain a lot of close contacts with the medical team. And it's really, really telling when a patient comes in for an initial visit, who comes with them to the visit, who might be on a telemedicine visit with this patient, how can the patient identify their care team and support structure. And a lot of times this really is apparent, and it's so important, I think, to have that team, because this is really a team sport, and especially with regard to toxicity management, clear communication and involving other loved ones, family, caregivers. It's critical to the success of this treatment, and especially some of these more aggressive combinations.
Yeah, it's a great point. So, Dr. Bastow, one of the questions I often get asked about, by fellows, by other physicians, and importantly by patients, is for patients who have a BRAF mutation, they have not only all of these immunotherapy options, but also FDA approved targeted therapy options that can be very effective. And this is really sort of an area where we haven't really had prospective clinical trial data until recently. And I think, as you and I have talked about, this is some of the most important data that we've seen in a few years. Would you like to talk about sort of again what we know now about the comparison of upfront immunotherapy versus targeted therapy in stage 4 melanoma patients with a BRAF mutation?
Absolutely. So this has been one of the long debated issues in melanoma. Do you start a BRAF mutant patient with BRAF plus MEK combination therapy? So that's either dabrafenib plus trametinib or vemurafenib plus cobimetinib or encorafenib plus binimetinib? Or do you start that patient with some form of immune therapy? And we have data now from a randomized study that was run by Michael Atkins, and it was a cooperative group study. So really great success for the cooperative group model here. And it really showed that 2 years overall survival is better starting patients with nivolumab plus ipilimumab compared to dabrafenib plus trametinib. These were all BRAF mutant patients, and they either had randomization to dabrafenib plus trametinib, targeted therapy, or nivolumab plus ipilimumab. And this is the standard FDA approved dose of nivolumab and ipilimumab at the ipilimumab dose of 3 milligrams per kilogram and nivolumab 1 milligram per kilogram. So I think this really helped resolve the issue. I think the answer is ipi-nivo. Now, there are a couple of subtleties still from that trial that came out. And one of the interesting issues was that there was a crossing of the curves and that there were some early deaths in the ipi-nivo group. And so one of the questions comes up, well, now that we have superior 2-year overall survival for starting patients with ipi-nivo over BRAF-MEK, would you start everyone with BRAF mutant melanoma with ipi-nivo instead of BRAF-MEK? And I think the answer is most patients, certainly yes. However, there's still some of these people that have these early deaths with ipi-nivo. And those are the patients that are really, really sick. And you may want to consider, at least in my feeling, BRAF-MEK inhibition in some of those patients. These are people that might be on steroids for brain metastases. That could be another group of people to think about BRAF-MEK inhibition. So I think there still is some role for BRAF-MEK in the front line and very, very selected group of patients, but I think the vast majority should have immunotherapy in the front line based upon the DREAMseq data. Ongoing questions about different, how good is nivo-rela in this setting and single agent PD-1 versus BRAF-MEK. We don't really have data on that, but I think that the nivo-ipi superiority over BRAF-MEK is really telling.
Thanks, Mike. That's a great review of those results. Are there any other sort of recent trials or advances that you have found particularly interesting or impactful in our field?
One of the other areas that's been really kind of a logical consideration is, well, what about triplet therapy, and what do we think about BRAF plus MEK plus immune therapy? We just spent some time talking about immunotherapy or targeted therapy. And I wanted to highlight this just for a second because I think my general take on this, and I know there are some different opinions around the field on this issue, but my general take is that's been a little bit disappointing overall. There was one positive phase 3 study with Cobi and atezolizumab over vemurafenib and cobimetinib alone for investigator-assessed progression-free survival benefits, although the independent review on that progression-free survival benefit didn't really bear out. And there was another negative randomized phase 3 study of dabrafenib and trametinib and spartalizumab in this space. So kind of how much concurrent PD-1 or PD-L1 therapy really adds to BRAF and MEK is a little bit unclear, and certainly there's more toxicity. So I haven't been finding myself using triplet therapy in most of these patients, but I did want to kind of mention that has been an active area of investigation in melanoma treatment, and whether there are roles for triplet therapy in high-risk patient populations like patients with brain metastases. I think that kind of remains to be seen, and there was certainly some data at ASCO on that particular population. I know brain metastases will be the subject of a different podcast, so I won't get into all these details, but I think that's one area that we really have explored. The results aren't all that fantastic, and I still generally think about doublets for my patients in the clinic.
Yeah, I think that's a great point. As you pointed out, there's this new data about sort of the Atezo in patients with brain mets, particularly those with symptomatic brain mets, which are patients who haven't actually responded very well, even to the ipilimumab nivolumab combination. And again, ongoing trials are also looking at those triplets in patients who have already progressed on PD-1. So that question, do we switch from immunotherapy to targeted therapy or do we add? And I think those are some of the continuing questions that we have in the field and that we wait for more data on. As we talk about sort of groups of patients maybe that don't get as much benefit from immunotherapy, clearly one of the areas of challenge has been patients with non-cutaneous melanomas, and particularly those patients with uveal melanomas that arise from melanocytes in the eye. And there we have a new immunotherapy option as well. Do you want to talk a little bit about that?
Absolutely. So this is a fantastic success in the melanoma field, and that's a way that the patients present antigens. And so if the patients are HLA-A2, and you can do that testing on peripheral blood, then they have metastatic uveal melanoma, they could be candidates for tebentafusp. And tebentafusp is a new drug that kind of works like a matchmaker. It has two different arms to it. One arm grabs a T cell through something called CD3, and the other arm grabs an antigen called GP100, which is highly expressed on uveal melanoma cells. And essentially, it just, as a matchmaker, brings these T cells in close proximity with uveal melanoma cells with the idea that the T cells kill these uveal melanoma cells. So it has demonstrated an overall survival benefit in a randomized phase 3 study against investigator choice of treatment. Ipi-Nivo was not the control arm in that randomized phase 3 study. So one question comes up, is Ipi-Nivo better than tebentafusp? And we don't know the answer to that formally. But I think with the overall survival benefit of tebentafusp over other single agent immunotherapy options for patients with uveal melanoma, I do think tebentafusp is a frontline treatment option for patients with HLA-A2 uveal melanoma. And it's great to show that we can improve overall survival in uveal melanoma. We can run randomized phase 3 studies in this disease. And tebentafusp is really a first in class of these T cell redirecting therapies in solid tumors to get an FDA approval. So a real big success in a way that melanoma has been leading the field, and great for these uveal melanoma patients.
Yeah, no, that's a tremendous step forward. And so maybe just one last question for you, Dr. Postow, as I sort of alluded to earlier on, we're really focusing here on the treatment of patients with unresectable stage 4 or stage 3 disease. We do know that immune checkpoint inhibitors are now also approved in the adjuvant setting for patients with earlier stage of disease, for surgically resectable stage 2 or stage 3 disease. And we're increasingly seeing now patients presenting with stage 4 after receiving adjuvant immunotherapy. And just wondering what your thoughts and perspective are on how this will impact or influence your thinking about the management of our stage 4 patients.
So great question. And this is an area that we need certainly a lot more research about efficacy of some of these new combinations after prior PD-1 exposure, especially in the adjuvant setting. Is there different efficacy expected if patients are progressing right on adjuvant PD-1, or what if they've been off of PD-1 for 3 months, 6 months, 1 year, 2 years, 5 years ago? Is there differential efficacy for some of these combinations? I don't think we know a lot about this, but one thing I would say is if I have a patient in the clinic that's progressed on adjuvant PD-1 or very soon after discontinuing adjuvant PD-1, I'm a bit more inclined to treat that patient with nivolumab plus ipilimumab rather than kind of going back on single agent PD-1 or even nivolumab and relatlimab. And that's because my feeling in general. And so in that context, I would think about nivo-ipi a little bit more for frontline treatment of metastatic disease, especially if the adjuvant PD-1 was given recently. But whether a break off of adjuvant PD-1 restores some additional sensitivity to nivo-rela or even single agent PD-1 after certain amounts of time, I think we need more data on that. And hopefully as time goes on, we'll collect that information and know how best to treat the patients in that new setting.
Well, Dr. Postow, thank you so much for joining us today. And really, our conversation really does actually work as a great lead in to the other podcasts that we're going to have in this series, including podcasts focusing on immunotherapy resistance, the management of CNS metastatic disease, and adjuvant and neoadjuvant therapy. So, thank you again so much for joining us today.
Thank you very much. I appreciate it.